I came here for 6 months, and during these 6 months is where Doc proposed to stay here as a postdoc, and I gladly accepted. So now I moved to Montreal, that I'm working with Nicolas Chemont, and I'm still working in reservoirs, and today I will present you the story of some babies. What does HIV cure means? And here I'm putting an example of one of the mothers of the cohort that I'm studying, that says that the cure for this mother will be that my baby and I are born again. My baby will have a normal life, and people will not stigmatize us. So this is really important. So the cure is not only that people don't take the pills anymore, but also is about stigmatization. And in Thailand, that is the core that I'm working in, the people who are living with HIV, they're having a lot of stigmatization, so they cannot find a word if they know that they're seropositive. So imagine like the pediatric population, so these child started as that they're infected from the birth, how difficult it can be for them. So putting in everything a little bit in background, they have been great interventions and to prevent the vertical transmission, and they're really successful. However, there's still a lot of new infections every year. There are estimated like 180,000 new infections, that vertical transmissions. And compared to adults, the acute infection in children it's much more, they are characterized by a higher peak of viral load and higher set points of viral load that leads to a rapid disease progression and to AIDS that usually is within 1 year if they're not treated, and then to the death after 2 years. So that's why it was really clear that early treatment was necessary for the babies, and as you can see here, pointer is here, the ones that they are treated really early, they have a decrease of morbidities and mortality. So that's why in 2016, the WHO recommended that all the children that they are born from a mother that is that could potentially be a vertical transmission, they should start a prophylaxis of 2 drugs for at birth for at least 6 weeks, for 4 to 6 weeks, and then as soon the diagnosis is confirmed, and this is by HIV DNA testing, so this is a problem because it requires some specialized centers, they should start the treatment immediately, and this happens between the 2 and 3 months of age. So as you see, there is a gap, and this is a little bit the point of my presentation today. So as you may imagine, in really similar to adults, early ARV will limit also the HIV reservoir in the pediatric population, and there has been also a lot of some studies of pediatric population that they have interrupted ARV to see how they go. And really similar to adults, there are some studies when the infants or the children, they stop ARV, they will run really fast. However, they have others, like the famous case of the Mississippi baby, and now also the French adolescent and the South African baby also, that they were able to maintain a viral suppression without treatment for a long time. So that's why we need to better understand the HIV reservoirs in the pediatric. So these slides maybe you all know, you may know already, but just to have a little of background, we can measure the HIV reservoir in different ways. So the first one is to PCR-based methods, who are really sensitive, but they take a lot of defected. So only around 10% of everything that we're measuring, it's something that we care. And in the other side, we can do like more relevant assays, as the CUVOA, to assess how many replication virus there is in the population, in the CD4s. However, as you may think, in a pediatric population, that when you can only get 1 tube of blood, it's kind of difficult to have this kind of assessment. So in the lab, we thought of different ways that we can have a more functional measure, but that it doesn't require as many cells as the CUVOA assay. So what we did is to look for an induction assay that we call TILDA, that we activate the cells and then look for multiply splice RNA. So how it works is that we take CD4 from the babies, and then if they are viremic, we do a version when we put the CD4s in a limiting dilution, and then by RT-PCR we'll look for multiply spliced HIV RNA, and this will give us the multiply spliced RNA at baseline, meaning the active replication. But we can also stimulate the cells for 12 hours, so that will reactivate the latent reservoir, and also after that put the cells in limiting dilution and have the frequency of cells have the frequency of the inducible reservoir. And so coming with that, so the aim of the study was to measure the establishment and the persistence of the HIV reservoir in a parenterally HIV-infected Thai children who initiated ART within the 6 months of life. So for that we had access at 2 cohorts. So the government of Thailand is doing a great job in trying to do a network that all the infants that they have been, that they know that they have high possibilities to be infected, they put them in a prophylactic treatment. And they're not following the WHO guidelines, so they're following the Thai recommendations that it's for prophylaxis, they use a nevirapine-based triple therapy. The doses are not the same as ART, they are suboptimal, but still there are 3 drugs. And this is for the cases of high possibility of transmission, or AZT alone if the mother is kind of well controlled. So then we have 2 cohorts. The first one is a longitudinal cohort. So we screen, so all the babies that they are potential risk, they have a PCR at birth, and they are put on prophylactic ARV. And then when infection is confirmed, they will start ART. And as you can see, we have several samples before ART initiation, and then we follow them once a year for 3 years. Then we have a second cohort that is a cross-sectional cohort. It's an older cohort, and that we used as a confirmatory study. So what happens to the infants before ART initiation? So if we plot viral load with the different measures of HIV reservoir, total or integrated, or the inducible reservoir, we can see that there is a positive correlation with the viral load with all the measures of the HIV reservoir. So that means, does it suggest that the magnitude of viral replication will drive the reservoir? So here in this population, we're mixing 2 kind of groups, the infants that are still on prophylactic treatment and the ones they have interrupted, because as I was saying, it's only for 6 weeks, and they start ART after when the HIV is confirmed. So we separated we subgrouped the infants in 2 groups, the ones that were still on prophylaxis and the ones that they took the prophylaxis, but the HIV was not confirmed, so they stopped the prophylaxis and they have been a while without prophylaxis. So as you can see, when we subgroup these 2 groups, we have differences in age. Of course, this group is younger because they only have been 6 weeks on prophylaxis. And also what is important is that they have the HIV transmission, it's really different between the 2 groups, and the ones that have been infected in utero, they are still on prophylaxis, and they are put on ART right away after prophylaxis. So when we do this kind of distribution, what we see is that the ones that have been on continuous prophylaxis, they have lower viral load. So that means that the prophylaxis, it's working, so it decreases the viral load. And when we look at the HIV DNA, we can clearly see that the ones that are still on prophylaxis, they have lower levels of total and integrated HIV DNA. So what happens to the inducible reservoir measured by the Tcell assay? So since they were viremic, we measure ex vivo and then after stimulation, and we can clearly see also differences in the active replication between the 2 groups. And what is important here, and in the continuous group as well as the one that is continued, there are a significant increase between the active replication and the latent reservoir. That means, so there is an increase between the ex vivo and stimulation condition. That means that the latent reservoir is already established even in the babies that has been treated since birth. So We wanted to know, so this little period that the babies don't have any prophylaxis, how it could affect to the viral reservoir. And then we found that the longer you wait, the longer is this time, the higher will be your reservoir. So what happened after the infants start ART? So this is from the longitudinal study 1 year after, and as you can see, there is a huge decrease of the total and integrated HIV DNA in all the infants. However, this is quite different from the early treated cohort of the Thai adults, that because these babies they are starting ART within 6 months, and most of them like within 3 months. And in the early Thai cohort, there are a lot of adults that are undetectable, which is kind of different that we see in the infants. And when we look at the latent reservoir, we still see a huge decrease also of the latent reservoir. However, it's undetectable in 50% of the children. So we have kind of a little discrepancy between the levels of total and integrated HIV DNA and inducible reservoir. That I will come discuss that later. So what is important if we correlate, because we have some babies that we had it before ART initiation and after ART, after 1 year now of ART, we can see there is a nice correlation. So basically where you start, it's where you will end up in terms of the HIV reservoir. So we wanted to know the impact of also the direct transition from ARV to ART with the ones that they had discontinued this treatment, discontinued the prophylaxis before ART initiation. So we did the same kind of division as we did before ART initiation. And as you can see, there are some differences in terms of clinics. The age again is younger in the one that had a direct transition. We confirmed that the viral load also with more infants at V1, like before ART initiation, was lower in the babies that they had a direct transition compared to the ones, so the prophylaxis was working. Again, we have the HIV transmission that in utero, so more babies that they are infected in utero, they have a direct transition from ARV to prophylaxis treatment to ART. And then, of course, the age of ART initiation, which is younger, the ones that have a direct transition. So what happened to the reservoir? So what you can see is that the initial differences that we see before ART initiation, they are still there. The babies that had a continuous treatment since birth, they had lower total and integrated HIV DNA compared to the ones that delayed their treatment. And for the inducible reservoir, as I saw you before, most of them, they were undetectable, or 50% of the cohort is undetectable, so which is quite a lot. And when they're detectable, the levels are really, really low. So there are no main difference between these two groups in terms of the inducible reservoir. So again, we did some correlations of this time that the time that they interrupted the treatment, so between the prophylaxis and ART, and we see that there is some correlations, not very nice, but there is correlations between this gap and the HIV reservoir. So the longer you wait, the more you have HIV DNA. So we took advantage that we have like this longitudinal cohort, and that we were followed for 3 years. And as you can see here, I'm plotting the viral load, and as you can see, as I was showing before, the babies with that were still on prophylaxis, they have lower viral loads. Then after 6 months on ART, most of them, they were already undetectable, and then they became undetectable for the rest of the cohort, for the rest of the years. While the ones that they have an interruption in their prophylaxis treatment, it took longer to them to become undetectable. So what happened in terms of the total HIV DNA, integrated HIV DNA longitudinally? So what we can see here is that the initial differences that we found before ART initiation that were maintained after 1 year, they are still maintained after 3 years on ART. And so the differences are maintained, but what is important, I think, in this graph also, is that the decay rate is similar between groups, meaning that there is still a good advantage of starting ART within 6 months of age. So in terms of the inducible reservoir, both groups decayed really fast, and the main difference is it's because the group of delayed ART has a steepest decay because they started from higher, but at the end they become almost all of them undetectable. Half of the cohort is undetectable. So we took advantage of the cross-sectional cohort of the other cohort that is a little bit older, so they were not following exactly the same guidelines as the previous cohort. So in this cohort, we were able to separate the children in 3 groups. The ones that had a direct transition from prophylaxis to ART, those ones that the same group as before, that they had prophylaxis, they stopped and then they initiated ART again, and the ones that never received prophylaxis. So when we look at it like this, we have, this is like a confirmatory cohort that we see the differences that the ones that have continuous ARV, they have lower total and integrated reservoir. And even here, we don't have so many children. We can clearly see that the ones in continuous ARV, they have a lower inducible reservoir compared to the other ones. But what I think is more important, it's that when we compare the one that had discontinued prophylaxis with no prophylaxis, that they have and didn't have prophylaxis at all, there are no main differences. So meaning that if you take prophylaxis, but if you interrupt it, then it doesn't have any value. So you lose all the good of the prophylaxis in terms of the HIV reservoir. So the conclusions for this first part is that controlling viral replication with the continuous prophylaxis limits the size of the initial HIV reservoir, and that the direct transition from prophylaxis to ART treatment at younger age are associated with lower HIV reservoir. And the longitudinal study confirms this cross-sectional study, and that the initial differences in the reservoir between the ones that had continuous ARV treatment and the ones that had delayed ART are maintained over the time. And importantly, the HIV reservoir decay after ART remains like the decay, it's really similar between groups. So, and the importance of this longitudinal, the cross-sectional cohort confirms the results from this longitudinal cohort, and I think it's really important that there is no additional benefit of the prophylaxis if the treatment is interrupted. So overall, this study, I think what we propose is that we need to extend the prophylaxis treatment until HIV infection is confirmed, to try to limit the size of the reservoir in the pediatric population. So this study came, as I was saying before, we had like a little of discrepancy between the levels of total and integrated HIV DNA and inducibility. So we were wondering if, because in the pediatric population, children have a lot of naive cells, which we know that they are more difficult to infect. And so we wanted to know where is hidden this HIV reservoir in the pediatric population, and to know if this reservoir is less inducible compared to adults. So for that, in some of the patients, we had enough cells to run some CUVOAs. So despite, again, so the CUVOA, so here we have the total and integrated HIV DNA, the Tcell assay, and the CUVOA. So despite that the levels of total and integrated HIV DNA were detectable in almost all the children, only 62% were able to produce multiply splice RNA after stimulation, and only 50% of them were able to produce replication competent viruses. And as you can see, there were 2 of them, but the levels were super low. So meaning that there is a problem, we think that there is a problem in inducibility or as I can say, maybe it's a problem that where the cells are hidden. So for that, what we did, it's what we call, what we develop in the lab, the HIV flow. So it's a flow cytometry-based assay to detect P24 proteins after stimulation in the samples from the babies. So what we do is we enrich for CD4s and then activate with PMA anomycin, that is a really strong stimulator, for 24 hours. And then we'll stain them for different markers to look at the subsets distribution, and also to look at the P24 proteins by 2 antibodies. So for that, then we can look, this is an example from an adult that we can see, this is the CD4 T cells, and this is the 2 P24 antibodies, and the double positive are the population that have been reactivated with the PMA anomycin. And since we have the markers to determine the CD4 T cell subsets, we can determine in which CD cell subsets they are coming from these double positive cells. So, as I was saying before, the T cell distribution in the infants is really different from the adults. So 80% of the cells are naive cells, and the memory compartment is less than 10%. So being the CM the most memory the most representative memory cells, followed by TM, and the EM, it represents all around 2% of the total CD4 T cells. So when we look again, we compare total and integrated HIV DNA tilde and the HIV flow assay as a second method or third method to look for inducibility. What we clearly see is that we have high levels of total and integrated HIV DNA, as again the tilde assay is lower, and for the HIV flow assay we had non-cells positive, so all of them were negative. So none of them were able to produce translational competent virus. So at the same time that we did this HIV flow assay, what we did is to sort the cells in 4 populations: the naive, the central memory, the transitional memory, and the effector memory, and look for the integrated HIV DNA there. And really similar to adults, what we see is that the effector memory are the population that is more infected, and followed by the CM and the TM, and the naive, yes, they get infected, but at much lower level. So, of course, when we look at the contribution to the HIV reservoir, what we clearly see is that the CM are the main contributor, even if they have less, they're less infected at the end, since the percentage is a little bit higher than the EM, then the contribution is higher. So leading that the CM are the main contribution, followed by the TM and the EM. So I don't have a end for the inducibility story. Just to tell you that in vertically infected children, there is a large compartment of naive cells that contributes to the HIV reservoir. And the CM subset seems to be the main contributor to the HIV reservoir, like really similar to adults. And although the high levels of HIV DNA are present in memory cells, these proviruses, we were not able to detect any levels of P24 protein after stimulation. So again, these results suggest that this latent reservoir is poorly inducible in R-suppressed children, and or there is an accumulation of defective proviruses in early treated children. So this is the work in progress that I'm working right now. I'm trying different ways to activate the cells to see if it's the problem is the way to activate it, because we activated with PMA anomycin for the HIV flow and tilde, and with anti-CD3, CD28 for the CUVOA. So maybe we need something stronger, or like different way, maybe, like it's both of them really strong. And for the accumulation of defective proviruses, we are trying to sequence the whole genome, like all HIV, the children, to look for that, but I don't have results yet. So just to finish, I would like to thank all the people that work in this huge in this huge study, especially all the people from Thailand, my lab in Montreal, and of course all the babies that they rock, and they have I hope they will have a good life. So thank you.